This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. How do they do this? Well, one way is by connecting like-minded individuals around a specific topic. We call these special interest groups, or SIGs. One SIG is a health promotion and wellness special interest group. I highly encourage y'all to check out some of the work they've done, especially with their presentation on physical activity, a key to successful aging. You can access this presentation for free and learn about how the AGPT can further your clinical practice at geriatricspt.org/SRP. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hello, friends. Welcome to the Senior Rehab Podcast. This is Dustin Jones speaking. Good to talk with you. Today's episode is pretty special. It's the third Wednesday of the month, and that means it is the Old Not Weak segment. So, from here on out, the third Wednesday of every month will be the Old Not Weak segment that will be led by Alyssa Kuhn. If you all are in the Facebook group, if you follow us on social media, you've likely seen Alyssa Kuhn has joined the Senior Rehab Project team. So Alyssa is a new grad from The Ohio State University. She is a CrossFit coach, but she is definitely one that embodies the Old Not Weak philosophy. She's done some amazing things in some of her clinicals and with some of her patients in terms of really breaking stereotypes and showing a lot of her older adult patients what they are truly capable of. She's been sharing a lot of her journey on social media, and it's just been a wealth of information. And I've really enjoyed kind of getting to know her, following a lot of the work that she's done, and figured, hey, let's ask her to join the team. I mean, she's putting out some awesome content. Let's give her the platform to do this on the Senior Rehab Project so she can help you all think about how to apply proper strength and conditioning principles in terms of scalability, to our older adult patients. So this is her first episode. So I'm excited. She's going to go just in a little bit, but first I wanted to give some time to the Academy of Geriatric Physical Therapy. So that is our sponsor. You heard that ad at the beginning of the episode. But once a month, we're going to try and just give them the opportunity to share some helpful information for you all, the listener, so you can become familiar with the AGPT, what they do, who their leadership actually is, not just a name that you read, but the people behind those names, just so you can become familiar with this organization that does a lot of advocating for a lot of us that are, physical therapists in a geriatric rehab setting. So, Greg Hartley, he's the president, El Presidente of the Academy of Geriatric Physical Therapy. He's going to share some information with y'all, and then we're going to get into Alyssa Kuhn's first Old Not Weak segment.
Hi, everybody. My name is Greg Hartley. I'm president of the Academy of Geriatric Physical Therapy, and we appreciate you tuning in to the Senior Rehab Podcast. We'll have a few minutes here up front to talk with a couple of esteemed colleagues. I'm joined by Dr. Keith Avon and Dr. Neva Kirk-Sanchez. Both Drs. Avon and Kirk-Sanchez were co-authors of a clinical guidance statement on falls that was published back in 2015 in PTJ. And we're just going to talk about right now what that is and how it is useful for clinicians. So let me start with you, Keith. Can you talk to us just a little about what a clinical guidance statement is and why that is important?
Sure. Thanks, Greg, for having me. I really appreciate it. First, a clinical guidance statement. I think most people are familiar now with clinical practice guidelines. These are evidence-based documents. The intent is to help reduce practice variation, improve outcomes, and they're really synthesizing the evidence out there and making recommendations about what clinicians should be or may be doing. As this push for CPGs has occurred, many organizations have clinical practice guidelines out there already. And so it can be confusing for clinicians to identify which CPG they should be using or which one they should have as their reference. So a clinical guidance statement first identifies which clinical practice guidelines are available on a topic. So for ours, it was falls. We identified that there were 3 falls clinical practice guidelines available. And so we look for similarities of the recommendations. We look for differences and then a gap analysis. So we're really providing a summary document for clinicians on falls across the already existing CPGs.
Got it. And so a document like this is why would we create something that's a clinical guidance statement as opposed to a clinical practice guideline?
I think to start, when you look at clinical practice guidelines, they're a big investment in time and resources. It can be anywhere from 3 to 5 years to create this document. So we really wanted to make sure that why recreate the wheel if it's not necessary? So we wanted to look and see which evidence is available and is it fulfilling our needs? And so that's really what the clinical guidance statement did. It identified, yes, certain components are being addressed from a physical therapy standpoint, but then there are some areas that need further research or time and resources.
Great. So Dr. Kirk-Sanchez, can you tell us then a little about what some of the key findings were?
Sure. So as Keith mentioned, we were able to identify 3 clinical practice guidelines that met our criteria and our level of quality for these recommendations. And we made recommendations in 3 areas. First, for falls screening. Second, for components of a multifactorial assessment. And then finally, recommendations related to multifactorial interventions. So to go in a little bit more detail, what we recommended was that physical therapists should ask every older adult patient that they see if they've fallen in the previous 12 months, and should also ask about the context of those falls, and also to find out if the patient feels they have difficulty with walking or balance. And if they do have difficulty, the physical therapist should observe for balance and gait impairment. A positive fall screening would suggest that either they have multiple falls or there is one fall and a perceived problem with gait and balance. So those are the recommendations for fall screening. We also were able to make recommendations related to multifactorial assessment. So if a patient screens positive for falls risk, the physical therapist should provide an individualized assessment of that patient within the scope of physical therapy practice. This should include medication review and medical history for key risk factors that are known. And they should also complete a full physical examination to examine balance and sensory impairments, limitations in walking and gait, and also provide referrals or consultations to other healthcare providers if problems arise that are outside the scope of practice. And then finally, for interventions, the recommendation we were able to pull from these clinical practice guidelines was that physical therapists must provide individualized interventions to address all positive risk factors within their scope of practice, in particular, individualized strength and balance training and gait training and correction of environmental hazards and footwear.
Great. So based on all of those findings, from screening to assessment and to intervention, what's the take-home message for practicing clinicians that are listening today?
So I think it's important for clinicians to understand that this screening for falls should be applied to all older adults, regardless of their presenting diagnosis. Asking about falls should be part of every episode of care, and a multifactorial assessment should be completed for all those at risk. In addition, appropriate referrals are important. And finally, targeted interventions to address positive risk factors should be part of the plan of care for all of our older adults who are at risk for falls.
Great. Yeah, that's super important for everybody to understand, is that every older adult should be screened for falls, regardless of the reason for the referral and why they may have come in to see you as a physical therapist or even an occupational therapist. So, Dr. Avon, tell us a little bit about what is next in terms of next steps relative to this particular guidance statement. And is AGPT working on other clinical practice guidelines that might be of interest?
Yeah, thank you. So for this current one on falls, I think we all were hoping to provide a greater level of specificity in terms of some of the dosing and some of the interventions that were specific to physical therapy. And that's really what we're hoping to provide now. We're working on a clinical practice guideline, myself and Neva, Dr. Tim Hankey, Christine McDonough. as well to provide a greater level of specificity for this fall's clinical practice guideline. We're hoping to have this done within the next year and a half is our goal. If all things go well, possibly a year. And then we're also working on an osteoporosis evidence-based document. We're sort of in a similar phase where we were with the Falls group when we have to identify what's out there, what's available. From an osteoporosis standpoint, we know there's about 8 clinical practice guidelines that are relevant to physical therapy. Now we're really trying to identify which ones have consistent recommendations, meet the quality, and then provide a similar document. Again, making sure that we don't go straight to the CPG because it's, again, a lot of time, money, and resources. We want to make sure that we're providing and being most efficient with our time. We also have a HIP revision. So when you start making a clinical practice guideline, this is something that stays with you. Every 5 years, we like to do revisions to make sure the content is up to date and consistent with practice. And so the HIP revision should be coming out within the year as well.
Great. So there's a lot coming and a lot of work happening, it sounds like. Let me point the listeners to a web link where you can go to get full text copy of the clinical guidance statement that Drs. Avon and Kirk Sanchez have talked about today. That link is www.geriatricspt.org/SRP. Once again, www.geriatricspt.org/SRP. And there you'll find links to the full text of the clinical guidance statement, along with some other resources that are relevant to this topic, including a systematic review on the functional outcome measures that was put together by the Jerry Edge Task Force. Anything else you two want to add? Did we hit it all?
I think we hit it all.
All right, great. Well, thanks everybody for tuning in.
Thanks for having me.
Thank you.
All right, good stuff. Thanks, Keith, Neva, Greg, for that helpful information. Listeners, if you want some more helpful information and resources from the AGPT, go to geriatricspt.org/SRP. That's geriatricspt.org/SRP. And they have brought together a handful of free resources, papers, presentations that'll be helpful for you in your practice, just for you, the listener of SRP. So you're pretty special. So go to that link. Link is also in the show notes. And you can find out how the AGPT can also help you just be a better clinician and how you can kind of join forces with them and what they're doing. All right, next up, Alyssa Kuhn, y'all. I'm excited for y'all to get to know her. So she is going to be doing these episodes. First, she's going to do them on our Facebook page as a Facebook Live. So if you are not in our group, which I have no clue why you would not be in our Facebook group, if you have a Facebook account and you listen to this podcast, you got to get in this group. But she will be notifying everyone when she's going to do this Facebook Live, so you can interact, in real time and be able to watch the video. But then we're going to take that audio and put it on this podcast. So third Wednesday every month, Old Not Weak segment. Here's our first one, talking about circuit training. Take it away, Alyssa.
Hey guys, so it's Alyssa here. Sorry I had a little bit of technical difficulties to get started, but I'm excited because I'm here for the first episode of the Old Not Weak podcast. That's going to be every third Wednesday of the month. Just going to kind of be talking about random fitness topics and kind of how to incorporate fitness principles into rehab settings across the continuum, with obviously a focus on older adults. So today I kind of wanted to dive into circuit training. So we all know, or if you're familiar with, the fitness realm, we all have probably done some sort of circuit training. Basically, what circuit training is you have a few exercises, and basically you go through each exercise. So say you have 5 exercises, you go through each exercise with minimal rest in between, and then you take a rest after the circuit and repeat a few times. So a couple things just to kind of point out about circuit training in general. So you can take it across a wide population of people. So it's a very flexible way to train. A lot of group exercise classes focus around circuit training just because It's easy to adapt to whoever you have in there. You can play with the intensity. You can play with exercises. So it's very easy and pretty quick to implement. So if you think about one of the main things is the rest intervals. So the work to rest ratio, they call it. A common one is 1-to-1. So if you do the exercise for 30 seconds, then you're going to have a 30-second rest break. So that's the 1-to-1 ratio. You can also progress to 2-to-1. So you're working for 1 minute and then you're resting for half that time, or working for 30 seconds and resting for half that time. So the overall goal is to just minimize that rest time in between. And then the best thing about circuit training is that you can use literally any exercise that you want, which is why it can be very applicable to the rehab setting, just because it doesn't need to be all of these crazy exercises with all these machines and, lifting as much weight as you can. You can do it with any exercise. You could do it with leg extensions. You can do it with sit to stands. It's all kind of the same, doing the same thing with the same goal in mind of strengthening and improving aerobic capacity and those types of things. So that's just circuit training in general. And now we're going to just kind of dive into how it applies to the older adults and into the rehab setting in general. But one of the main reasons why I looked into this specifically is because when I was on my last rotation in a SNF in an outpatient orthopedic, mainly in an older adult population, I heard probably 20 different times in each treatment session, how are you doing? Like, do you need a break? Do you need a rest break? And it was coming after almost every exercise. So then I got to thinking, like, do older adults really need this much rest? Are we really giving them the best results that they can? And so then I started looking into circuit training and trying a few things to experiment in the clinic. And what I found was that this is definitely feasible in this population. And I was able to kind of experiment with this, but I'll talk about that a little bit later. But the main reason is, if you think about it, if you were working out and somebody kept asking you if you need a break, well, if you don't actually need one, but you're like, oh, well, I'll sit down for a second. So it's not necessarily that they need these breaks, but if we're continuing to ask them, then, you can't say no to a rest break. So, but then in retrospect, if you think about how much time you're actually taking to rest compared to how much treatment time you're doing, they may be very different. So I want to take this circuit training principle to kind of maximize our efficiency in the clinic so we can help our patients maximize their results. So I know a lot of people are thinking, okay, circuit training, well, what if my patient has, congestive heart failure, they had a stroke, they had a heart attack, they have all these different comorbidities. Is this feasible in those populations? And it turns out it is. So I was looking at a few articles and I came across a meta-analysis that looked at whether this works to improve strength for middle-aged and older adult patients. So what they found was across 10 studies, they found that circuit resistance training was able to be safely applied and can enhance both upper body and lower body strength in a diverse population. So across these 10 studies, each study kind of looked at a different comorbidity. So there was stroke, post-heart attack, coronary bypass, hypertension. Quite a few of them looked at obesity. So there's a wide spectrum of people that this can apply to, and it is safe to, hey Troy, and it is safe to use with these patients. Obviously, there's different intensities that need to be used and different things to take into consideration as far as monitoring them. But at the same time, this is still feasible. Just because your patient has congestive heart failure doesn't mean they need to rest 5 minutes between each exercise. So I kind of dove a little bit deeper into those exercises, or into those articles that they looked at. And one study actually used, patients with congestive heart failure. And they looked at using circuit resistance training with these patients to improve aerobic capacity. And what they did was they had various exercises. So they used leg cycling, elbow flexion extension, stair climbing, arm cycling, knee flexion extension, and shoulder push and pull. Like, that was it. And it was an 11-week program. And they did this circuit 3 times each time they did it. And then they did it 3 times a week. So you're looking at about 30 minutes or so per session. So definitely feasible for us. Some of us may have 30 minutes, some of us may have an hour. So, and what they found was that they were able to improve aerobic capacity in these patients. And one thing to take into consideration, especially with congestive heart failure, is they did look at appropriate intensity. So obviously, we're going to need to scale some of these things and monitor some extra things for these patients that may have these comorbidities. So what they did is, in order to determine the recovery time, so they did each of these exercises for 30 seconds. And then at the end, after they did each exercise, they looked into the recovery time. And I think personally, this is probably one of the hardest things to decipher and figure out what the appropriate time is. And what they use is they just rested for as long as they needed until their until their heart rate was within 10 beats of their resting heart rate. So that is one way to do it. And then they monitored the intensity through heart rate as well. They reduced the intensity if their heart rate was within 5 beats of their peak heart rate. So heart rate is one way to do it, to help monitor these things. You can use a pulse ox. That's probably the easiest way. And that's one of the ways I also did it in the clinic. Also using RPE is another way to if your patient doesn't have these specific heart conditions, or they're controlled, you can also use RPE because it's kind of quicker and a little bit easier to kind of figure out. But that is one way that they documented how to do it. So, like I said, you can do all sorts of exercises. There was an interesting study I found that they only use body weight exercises for these circuit trainings, and it was based on a home program for older adults. So they gave them sit-to-stands, hip extension, flexion, calf raises, side leg raises and standing, and then trunk flexion and extension seated. And what they found was, so these patients were between 53 and 76, and they did each circuit, so all those exercises for 3 minutes, and then they did that 3 times through. And they found significant strength gains in both knee extension and plantar flexion strength. And it was interesting because in the discussion, they brought up a point about, why not we just do a walking program? Like, why is circuit training better than, giving these patients just a walking program? And one of the studies found in this walking program, they only improved plantar flexion strength, but didn't improve knee extension strength. So it can kind of hit a few different things, which, obviously isn't rocket science, like just doing walking versus doing a few other exercises. We would think that it obviously would improve different things, but I just thought it was kind of interesting because, again, it's also feasible with body weight exercises. You don't even need resistance training to improve strength. So again, we could also use circuit training as a home exercise program. And you could if your patient, maybe is having a hard time with adherence or needs a little bit more direction, even, using circuit training as a home exercise program might be a way to kind of approach it as well. So I just wanted to point out that circuit training can be applied to various patients, no matter what the comorbidities are. And so on my experimentation, so I was able to kind of take these principles and use it. I was treating mainly outpatient, but it was in a retirement community. So most of my patients were between 80 and 90. So I was able to use it on a patient that I had that had just had a recent hip replacement. And so I honestly think that this also makes our job a little bit easier, because you take maybe for that exercise or for that session, you want to work on 3 main things. And so you pick the 3 exercises that you think could best approach these impairments. And then you just repeat them. I found, and I know a lot of you probably have found this as well, that older adults like routine and they like repetition. We can't just throw a bunch of new exercises at them at once. It can be a little bit overwhelming to them. So I had a really good response in that way. So I took, 3 exercises. We did a staggered sit to stand, static lunge hold, and then a resisted sidestepping. And I did each of those for 1 minute and then rested for about 2 to 3 minutes, and then monitored using RPE. And he really loved this. We went through it 3 times. And then depending on if the exercises were super easy, I made it a little bit harder the following time. So maybe for that sit to stand, I put a piece of foam underneath his uninvolved leg, to encourage more use of his, involved leg. So you just kind of have to be able to adapt on the fly, but you have those core exercises in mind already, and you're just repeating through them. So it makes our lives a little bit easier as well. So I think that an interesting thing is I think it adds a cognitive piece too. So this guy who had just recently had his hip replaced also had some minor dementia. And so you're doing the same 3 exercises. So the next time through, you ask, okay, do you remember what this exercise was? And it kind of gets those cognitive gears going as well to kind of figure out, oh, okay, like I don't remember. And then you'd remind them and then keep trying to test them to see if they're able to recall anything. Cause, there's obviously benefits with dual tasking and things like that. So it's definitely just an additive piece that, can help those patients. So the patients that I used this on were, across the board functional wise. Like you can use this in patients who are wheelchair bound. You can use this in patients who are, pretty acute from an injury. So if you're looking at like an acute care setting, you can apply these. So if you say, okay, we're going to do 30 seconds of seated marching, and then we're going to do 30 seconds of a sit to stand from a raised bed, and then we're going to do a walk to the door and back. It's the same principle of using, circuit training. You might need a little bit of time in between each exercise depending on how they're responding, but it's definitely a way to kind of mix things up. And I think that sometimes it's pretty easy to get into a rut and, get into your flow of therapeutic exercise. And sometimes we need a fresh perspective, kind of how to mix things up a little bit. So I think this is definitely a way to do that. I was presenting on an in-service using circuit training in this retirement community to both outpatient and SNF employees, physical therapists. And one of the PTs that were in the meeting was like, well, I don't think that this is all great, but I don't think this really applies to a SNF setting. And it actually does, which I hope that I proved. Like you can, do any exercise that you want, even if it's all seated, even if it's, all standing, depending on the level. So it's very modifiable. So again, across all settings, feel free to kind of mix it up, experiment, and see what happens. Some patients might obviously respond to this better than others, so it's one thing to kind of play around with and one thing to kind of keep in the back of your mind. Because an interesting point that this meta-analysis brought up was that circuit training does have the ability possibly to improve exercise adherence. Due to its shorter duration. So it doesn't need to be, a super long, program. It can be 20, 30 minutes. It would definitely be an easy way to talk someone into a home exercise program. If you do these, 4 exercises, maybe 12 minutes, and then you're done. So it's definitely a way to keep somebody on track, and maybe that can increase adherence that way. And it's just a different way to structure things. if someone needs a little bit more direction. One thing I did like about circuit training, and I didn't see any, research or anything on this, but instead of giving someone just like a set number of reps, I found that my patients were more apt to approach fatigue, muscle fatigue, when, they're doing as many as they can for a minute versus, do 12 when you have no idea if they're hitting muscle fatigue at 12. So that's also another way, especially for like a home exercise program, that, they may be responding differently to doing as many as they can in 1 minute versus 12. They might just be, banging out 12 and just on to the next one without approaching that muscle fatigue. So this is one way to also do that. So basically, in conclusion, this isn't earth-shattering information. I think my overall goal was to just show that circuit training can be feasible in the clinic with older adults as a novel way to kind of structure treatment sessions, structure home exercise programs. And the main thing, I think, is just decreasing the allotted time for rest and increasing our efficiency as PTs. And, kind of moving away from asking patients after every single exercise if they need rest. Because as we know, and as I know most of you have probably seen, older adults are so resilient. They're capable of so much more than we give them credit for. And I think that's what, obviously this group is trying to prove. So if we start moving towards using some of these novel treatment approaches and start using these principles and putting them to use in the clinic, I honestly think circuit training is very feasible to do in the clinic. The point is, I want you to be able to kind of take this information and be able to use it tomorrow. Just basically finding a core set of exercises, running through 2 to 3 times, depending on how they are responding, and kind of go from there. So I think it's both beneficial to our patients and to us as clinicians to, help improve overall results. So if you have any questions or anything, feel free to shoot me a message or anything you need to. I also have a bunch of examples and things of how to set things up and just a couple, exercise progressions I used in the clinic on a few different patients that I would be more than happy to send you. But that's it for the first podcast of Old Not Weak. And thanks for listening, guys.
Hit me! Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.